will be presented by Dr. Sheera KR. She is from Aradhanai Hospital, Trivandrum. She is going to present an atypical presentation of choroiditis. Over to you, Sheera.
Okay, move on to the first case. It's about a 32-year-old lady who presented with redness and pain in the right eye, which is lasting for around 1 month. In the systemic history, there was nothing significant, and she presented to us after a partial treatment from elsewhere with a topical and also oral steroids. Left eye was normal, and in the right eye, her vision at presentation was 6/6 and 6, and intraocular pressures were normal. Her anterior chamber showed 2+ cells, and anterior vitreous face showed 1+ cells. This was the right eye. Dilated fundus examination of the right eye. In the posterior pole showed hyperemic disc with the blurred disc margins, and in the periphery, inferior quadrant, infratemporal and the temporal quadrant, there was gray-white deep retinal lesions and with obscured blood vessels over the lesion, which was showing a track-like pattern, and there was a prominent lesion which was choroidal with a normal overlying blood vessels, and we were able to make out a significant amount of vitritis over these lesions. In the right eye OCT scan, the fovea was normal, there was no macular edema, but in the peripheral lesions, the scan sections through the peripheral lesions showed choroidal involvement and retinal and also overlying vitreous cells. This was the FFA picture of the right eye showing hot disc with a disc leak, and in the periphery there was hyperfluorescent lesions with minimal vasculitic changes. But this FFA was taken actually over a period of after a period of steroid treatment for around 1 month time, because she presented with a history of steroid treatment of 1 month duration. So we considered the possibilities of tuberculosis and serpiginous choroiditis and also DUSN also in view of the peripheral lesions, tracking like picture, and also hot disc and vasculitis changes. So we sent all the basic uveitic workup investigations, and nothing actually made grossly positive in those tests. Even HRCT test was done and physician evaluation done to rule out any underlying TB, infectious etiology, and also sarcoidosis. So the treatment given was, we continued with the topical steroids and also mydriatics, and in view of the DUSN, we started her on albendazole, and after starting albendazole 48 hours later, we hiked up the oral steroids. She presented with a oral steroid intake of 10 mg Vislon. We hiked up into 60 mg after starting 48 hours of albendazole treatment. Her course in the treatment was immediate follow-up after 1 week time. She showed the lesion size was reducing and the lesions got faded, and she was showing response to the treatment, and symptomatically also she was better. And but when the Vislon dose tapered to 10 mg, she again presented with the symptoms, and the lesion size started increasing, and also it started moving more posteriorly towards the arcade. So we actually referred to a higher center, Arvindai Hospital, Madurai. From there, vitreous biopsy was done and PCR test done. The reports came negative for TB, HSV, VZV, and CMV also. And again from there, she was treated with a oral steroid, topical steroids, and also a 1 more course of albendazole. On follow-up, but the lesion was encroaching more towards the macular region with different stages of the lesion. In the peripheral, there was healed lesions and few areas of the active lesion which was extending to the macular region. Again, all the blood investigations repeated there, and also FFA repeated at Aravind, which was showing early hypo and late hyper picture. And 1 year, 3 months down the line, she again came to us for the further follow-up. That time, this was the fundus picture with all the macular region, and the posterior pole was involved with the peripheral healed lesions, and in the posterior pole there was active lesions, and the disc was hyperemic and was showing disc edema also. This was the autofluorescence picture and the OCT picture of this late presentation. And when she again reviewed at Aravind Hospital, they repeated the PCR test for the same panel, TB, varicella zoster, herpes simplex, and CMV, but all the reports came negative. And they gave one injection of intravitreal steroid also from there, and continued with the topical and oral medications, low dose steroids.
Thank you, Sheera. Over to you, madam, for discussion.
I'll just use it. Hello. I think can we go back to the second set of pictures?
Can you make the slides on again?
So one thing is, the DUSN in its acute phase, has a clinical picture which is very different from its late phase. It's very important to recognize the DUSN in the early stages. And the cases which I've seen, they don't get, they generally get much smaller lesions, either in clusters or in tracts. Okay, it's very unusual for them to get choroidal elevation like this. So.
Okay.
Please go back to the next fundus picture. Yeah, hold it. So in this, if you see, you can see that there's scarring and the edges are active. I would go more in favor of a serpiginous choroiditis in this case, and since the biopsy was negative, the only other thing I might have done is go for a quantiferon TB gold, but I would have gone for immunosuppression in this case. So
Okay.
that's my take on this.
Any role for ATT, madam, here, even though
Since the two biopsies were negative, I would go straight for immunosuppression. I think they gave intravitreal steroids as well.
Yes, ma'am.
yes, Dexa.
Did that have any positive effect?
Yeah, immediately after the injection, she was showing good response, and her vision was improving, and all the infectious evaluation were negative. That's why.
Yeah. So even this so-called tuberculous serpiginous choroiditis, you'll see that many of these patients, in spite of ATT and oral steroids, they continue to have active inflammation, and you need to give them immunosuppression. So that's what I think is happening here.
Ma'am, how frequently, if you're suspecting DUSN and you've actually spotted a worm?
Very rare.
Very rare.
Yeah, so I think over the last 1.5 years, we've been doing a series. Actually, Dr. Meera has been. So we would have seen about 6-7 cases. It's more common than you think, and it's one of the most underdiagnosed diagnoses, especially in the acute phase. Okay, it's very commonly mistaken to be either choroiditis. Actually, those lesions are not at the level of choroid. If you run OCT, it's at the outer retina, and or like vasculitis or neuroretinitis. Yeah, so in that only one case. Yeah.
you better take a fundus photo so that you can spot the worm easily.
Yeah, so the good thing, that's a very good idea, because you can blow up the fundus photo, and the area you need to concentrate. So usually you get a mixture of inactive and active lesions, and you need to look for the worm near the active lesions. Okay, so you can blow it up and try to look for it. We have done that, but in spite of it, only 1 in 6, 7, it's very rare. But beautiful response to a combination of albendazole and steroids.
Then would some other imaging modality help in locating the OCT, peripheral OCT or something like that?
No,
Fundus photo will be the best,
yeah,
I think.
Even I agree with that. I don't know whether other modality, as in red-free or something, would be more useful. I'm not very sure, but fundus photo as of now.
And madam, tell a few clues how to go further when you suspect whether it is choroiditis or chorioretinitis. Can you give a clue how to go further?
So first of all, it's important to know the level of the lesion, whether it's retinitis, choroiditis, or chorioretinitis. You'll all know how to differentiate it clinically. The retinitis is more white in color with less defined margin. They look like large cotton wool spots. You can see the vessels passing through the lesion, and you get more of vitritis and hemorrhages as well. Whereas choroiditis tend to be more yellow If you look at the lesion, you can see the blood vessels are passing over the lesion, as you can see in the photograph here. More defined margins, and vitritis and hemorrhages are less common. So once you know what it is, the thing to do is to decide whether it's an infectious or non-infectious condition. In general, in real life, most retinitis is infectious. So this is something you need to keep in mind. Most retinitis is infectious until otherwise proven, whereas choroiditis, it could be 50-50. Yeah. So retinitis, it tends to be more of toxo and viral, and choroiditis, I think, TB and sarcoid.